Hello dear colleagues, this is Almaty, Kazakhstan, and case number 3 for today. Patient with the meningioma on the right frontoparietal territory. And now we can see there is a supply from middle meningeal, and I'm not sure about internal carotid territory. And let's check the ophthalmic. Ophthalmic is intact, looks like intact. Meningeal branches, posterior branch and anterior branch is supplying this huge meningioma. This meningioma has a edema in the brain, and we're expecting atypical meningioma, 6 centimeter, more than 6 centimeters, and yes, it's supplying from here to here, and this branch is also going there. Unfortunately, we finished all headway duo. For today there is no more headway duo, but we have sonic, and maybe we will go with sonic, and we'll work with sonic. We start with local anesthesia, but because of the size of the meningioma, we decided to ask our colleagues. We asked our colleagues to do it under general, because it should be quite painful. The size of the meningioma is too big, and this part also supplying from the right side, from the left side, and as expected. Yes. And yes, this at the beginning is less tortuous, and usually here is some connection, and it might be tortuous, and with crossing from one side to another it could be problem, but it's possible. First of all, we will start from the right side, and then we'll check the left side. Okay, vertebral territory is okay, but the idea was to check the supply from this vertebral artery and this occipital. Okay, it should be okay. I hope it should be okay. And now, Шейхмет, внутренний сон түсірдің ба отдельно? Yes, I'm asking Sheikhmet to check the intracranial, and surprisingly this territory is also hypervascular. It's a hyperostotic meningioma, yeah? And yes, it's all connecting. There is an aneurysm here. This is quite tortuous. I hope we can proceed this part, but it's quite tortuous, and this part is supplying from the another side, from left side. And I think this branch is straight. Okay, we can go from this. We can go from this. So not a lot of branches. Yes, it's supplying from the PL also. Usually it's atypical. Yes, it's supplying. Okay, we have two options. One is posterior branch of the middle meningeal. Then there is a middle branch, parietal one, and then it's a frontal nudge, but this part could be a little bit challenging because this is quite tortuous. And at this point, this okay, this might be okay, but this is not okay. Yeah? Okay, maybe we will take this one, and then through the collaterals we can occlude all this territory. Yes, we can cause some skin embolization. Okay, that's it. Some branches is going earlier and deeper. Maybe this one is go deeper. Okay, let's see. Касса, Ахмед, все, не свети. Окей, это ж плотно. Headway 100 research. Okay, let's try with headway 17 and Traxxas. Headway 17 and Traxxas. If we can proceed, then it's good. If it's not, we'll see. бір набор, екі набор шприц ашсаңыз. Объем үлкен. And we decided to take one more patient today, and the last two patients we will do tomorrow. One meningioma, petroclival, and one stenosis and intracranial, maybe for tomorrow. Даем себе results. Now we are collecting dimethyl sulfoxide, which is demeso, and then we will start. Там results. Okay. Hello. My name is Mynzhylky Berdikhojayev, and my assistant is Ahmed Shurikhanulu Mahanbethan. And all the time I'm talking about Kaizen, and it's meaningless. Yes, there is no meaning in my words. My young colleagues doing the same all the time. There is no Kaizen. No Kaizen. Individual approaches. No Kaizen. All the time different.
I think in medicine, Kaizen is not.
Medicine is Kaizen. If you standardize your approach, then the rate of complication is less. It was a movie, Dr. House. I think in many places it was. Have you seen the Dr. House? Yes. And the first series of the Dr. House, he's coming to the outpatient hospital and says, okay, you are 20 people, and half of them I can treat with the one pill of aspirin. Yes, and more than 90% of the patients, need a standard approach. Yes. And only 5 to 10% of the patients we need an individual. Okay, then it's a kaizen. Yes. Yes, maybe. Why not? That's why there is a protocols, trials, guidelines. It's a kaizen. When you follow the protocol, you can save 90% of patients, yes? And for the healthcare system, it's not important. You will save 90%, you will save 5%. The better to save more. It's a statistics. Yes. And then you can talk about individual approach. Huh? Yes. For some healthcare organizers, it's anarchy when you say about individual approach. Huh? We are living at the time of artificial intelligence, and in following years everything will be standard. Okay, there is a spasm, but it's not problem. Okay. Ташпылатна, гемодинамиканы көтен бір жазып жібересіз, мұны қайта секіріп отыр. Все, стоп. Осылай. Okay. I hope the autobahn of meningeal arteries will help us, and we can do it in a meningeal artery approach. It's also possible to go here. Yes. And I hope it's possible. Unfortunately, we have only headway 17, but in combination with Traxes, it should work. Traxes is distal. Yes, it's a small branch, and it's a big branch. Okay, we can go here. Yes, Traxes as much as distal. And the only problem is this is a headway 17 regular, and outer diameter is quite bigger than in regular headway. Okay. And I couldn't push it. I need to push. Yes, now it's coming. It's very tortuous anatomy. Okay. It doesn't want to go. Okay. Maybe now we need to take Chikai Black. Chikai Black пересаж. Yes, it's stacked. It doesn't want to go. It's a difference between headway and Texas. Headway and headway duo. This is quite stiff. Забирай. Даже бір тампон бере салшы. Чекай, бұрмай ақ қой, сразу сол күйінде бере сал. Yes, for more support. Ножки қоя сал, просто ножки қоя сал. For more support, we asked for Chikai Black. Chikai Black is more stiffer than Traxxas. Traxxas is soft. Let's see how it will work. Yes, if you will do it under local anesthesia, it's quite painful. To push the headway in the meningeal, it's painful. Okay, now we see the reason. It was some vent. Okay, it's a different wires and different behavior, right? You see? Now it's better. Navigation is better. Okay, you can go there, but it's stuck there. Okay, it went. It's quite surprising that headway 17 can do this distance. Huh? Okay, let's see. Sure, oops. Yes, it's two different type of wires, Traxxas and Chikai Black. And if you have both, it's better. If you have only one, then your ability to push the microcatheter is limited. Huh? Okay, you see now how many collaterals? We can approach from here all branches, yeah? Nearly all. Almost all branches. Also the superficial temporal artery, all three branches from meningeal. Okay. Okay. Yeah, okay, демосол. Наркоз поглубже, дексаметазон 12. Сквит, оник. Сразу веки убери солнце. Вытянулся, ага. Okay. It's very good approach when you start with fill 25 and then follow with the other liquid embolics. We call it fill first technique. Then the penetration is much more better. And the reflux is more stable. But unfortunately, microvention stopped delivering fill in Kazakhstan. That's why we should work in this condition. Okay. Many people is scaring to use only the squid 12 because there is a scary. The reflux is very weak reflux, not so stable. Glue. Okay, let's start. Она снимет туда находится. Последний снимет. Солнце. I'm asking Sheikh Ahmed to put the previous DSA. Okay. Да. Okay, let's start. It was a branch earlier, and now we are in the middle part. I think it's okay. Also, we are in a superficial temporal territory, and also we now approach the territory with the upper branch with only one microcatheter. Yeah? This tortuous part we discussed before. Yes, yes, this part. It's a little bit complicated to approach from that part. Okay, let's inject a little bit. Так, мынаны болсо. Мынаган остатыгын жинесиш. Екі флаконның остатыгын жинесің. Okay. Okay, now you can see how the squid is going. Yes, we have distance and we may continue. Now it will start to penetrate the tumor territory. Mostly the tumor territory, not the proximal part. It will penetrate the tumor, and our goal, we need to approach the contralateral collaterals. It's very important. If we will reach the superficial temporal and the contralateral side, it's very good. Okay. Yes. That's superficial temporal territory. Yes, it was. It was before, and this is a contralateral side. You see? Now we reach the falx territory. İşte kıyıcısın. Kıyıcısın. Tut. Stop. Келесі пациент әкеле берсінші, ташпауытына. Ja, өйткені мен қазір неге встречаға бару керекпін с школьниктарым. Анда қарайсаш, поверхностный височный қалай жүреді екен. Yes, we need to check the territory of superficial temporal to prevent the skin necrosis. Yes, all is going inside the tumor. And this is, I think, the superficial temporal. It's still supplying, huh? There is one more branch coming from somewhere. It's a muscular branch. Yes, it's a muscular branch, but it's also possible to cut with the cauter. Huh? Okay, let's try to inject as much as possible. And this is also the prevention of the I think there is a rupture of the meningioma now, but it's not problem. Okay. There is a sign of epidural leak. Usually when it's ruptured, it's leaking. But the size of the meningioma is 6 centimeters, it's nothing. Yes. Okay, now the most of the part of meningioma is occluded. Also, we took part from the superficial temporal. Okay, 2 bottles of Squid 12 and this result, I think it's okay. And there is no reflux, we are in a wedge position and the microcatheter is in a very good condition. There is no nearly zero reflux. Yes. Nearly zero. Yes, this part is extravasating, and I think we need to pull a little bit our microcatheter, and we may occlude this part also. Okay, this is the collaterals. Okay, maybe you will give me a little bit more liquid embolic. Okay, това в джини съм, наркотик. Yes, now the opening the dura will be more comfortable with no bleeding. Yes, it's also blood saving technologies. Yes, it's nice. One microcatheter. Yes. Добре, бери салс. Ау? Я ходя салс. На всеки случай. Но скорее всего, ходить помыть. Ну, I know there's ташплотно. Одно. Okay. It's okay, it's okay. It's okay. We're still feeling the meningeals with no reflux. It's good. I hope it's good. Now it starts refluxing. It's very important to see how much is reflux. Okay, till the temporal bone it's okay. Then it might be some risk of deficit. It's okay. It's not so much. It's not so much. This point is okay. It's inside the tumor. I think it's enough, and we can retrieve the microcatheter a little bit, and we need to fill this part also. It's also prophylaxis of epidural hematoma. Okay. Then we can inject a little bit more. There is a branch. Yes, it's mostly inside the tumor. Okay. Now we can finish. Yes, Spitzmann. Yes, I think we can say next patient, please. Okay, let's see like this. It's just 20 minutes of work, and I hope I saved 2 hours of microsurgery. Yes, and 1 liter of bleeding. Yes, the HIV and the hepatitis, there is no guarantee if you take the blood. It's all the time small risk of that's okay. Yes. There is small peel network from the brain part, but it should be not problem. Okay. Control CT. Excuse me, sorry. Okay. It's quite surprising that headway 17 could go this distance thanks to Chikai Black, with Traxxas. Okay. Let's wait for control CT and let's see how much we could inject. Okay. Okay, dear colleagues, the CT is ready, and you can see there is a mass effect, and this is a meningioma. It's quite big, and with the edema and with dislocation and mass effect, and this is the skin. It's already embolized, that's part also. Okay. Now we can finish this case. Next case is intracranial stenosis of supraclinoid ICA. And yes, this is a meningioma. We try to embolize as much as possible. On angiography, I think it was not seen like this. Let's see. Okay, let's take it out. Yes, this part was not seen so well, but it's good penetration. Yeah? Okay, see you in 25 minutes. Next case is ICA stenosis.